Добрый день, глубоко уважаемые коллеги. Мы продолжаем наше мероприятие. И мы переходим к нашей сессии международному заседанию, которое посвящено персонализированной терапии пациентов высокого риска. Но я хочу обратить наше с вами внимание, что речь пойдет главным образом об особенностях ведения наших пациентов в условиях эпидемии COVID-19. Мы все хорошо понимаем, в какой ситуации мы сегодня оказались, и проблемы наши заключаются не только в необходимости лечения больных с плохо изученной инфекцией, но мы все знаем, с какими сложностями мы столкнулись в плане лечения больных с другой патологией. И поэтому я думаю, что наше нынешнее заседание и вопросы, которые мы будем обсуждать в ходе этого заседания с нашими ведущими международными экспертами, даст как раз нам некоторые ответы на те вопросы, которые нас сегодня так волнуют. И я с удовольствием хочу сказать о том, что первые два докладчика, которых мы будем сегодня слушать, наши первые два эксперта, представляют Европейское региональное бюро Всемирной организации здравоохранения. И полагаю, что работа наша сегодня будет очень интересной и очень продуктивной. И я с удовольствием представляю вам госпожу Бенте Микельсен, которая является уже в течение многих лет директором отдела неинфекционных заболеваний Европейского бюро Всемирной организации здравоохранения. Она является признанным специалистом в области менеджмента и организации здравоохранения. И выступление ее будет посвящено COVID-19 и неинфекционным заболеваниям. Спасибо большое, и мы слушаем госпожу Микельсен.
Good morning, Excellencies, Ministers, Professor Schlachto. Thank you very much for inviting me to the 40th anniversary of the Almaso National Medical Research Center and the third Innovation St. Petersburg Medical Forum and Scientific Session in this October. I am very pleased to speak to you, and I'm so happy to sort of be back in St. Petersburg. It was a true pleasure and an honor to be invited, and I wish I could be with you. So I'm going to give you an update on COVID-19 and non-communicable diseases and building back better differently. And of course, I'm speaking to you with the knowledge that your support during the last years as a WHO collaborating center has been crucial both to the WHO Euro region, but also added value globally. And I sincerely hope that our collaboration can continue even stronger for the next 40 years. So as you know, we have 5 risk factors for non-communicable diseases: unhealthy diets, tobacco use, physical inactivity, harmful use of alcohol, and since 2018, also including air pollution. And at the same time, we have the 4 major diseases killing more people than any other diseases in the world: heart disease and stroke, cancer, diabetes, and chronic respiratory diseases, and since 2018, also including mental health disorders. We just published the last Countdown 2025 together with colleagues from Imperial College, NCD Alliance, Lancet, and WHO. And what we can see is that the SDG target 3.4, namely reducing premature mortality from NCDs with 30% before 2030, is off track. So as you probably know, the WHO Euro region is the only region that has really a chance to reach the target as a region. But if we look into the global figures, you can see that only 17 out of 194 countries are on track for women, and even less for men, only 15. So the good news is that if we are in implementing the best buys, the menu of policy options provided by WHO in countries, we are still able to make it, but the time is precious. So the journey has been going on since 2000, and actually in the years from 2000 to 2010, we had a nice progress. But the last 10 years, the progress has dwindled, and even we see that premature mortality, namely dying before the age of 70, has been increasing the last 10 years, and it has increased by 5% for diabetes. So what is the solution? Of course, you know this. I'm speaking to the global experts that really know and also develop many of these tools. But we can make it by reducing and modifying the risk factors through implementing policy, legislation, regulatory measures, including fiscal measures. And of course, what the COVID-19 has shown us, we really need to include NCD into the humanitarian response, the primary healthcare, and the universal healthcare. So the bottom line is that we need to address the NCD epidemic, and it's essential to strengthen resilience to the communicable pandemic diseases as well. So I've just given you the slide again to show you the premature mortalities in different income groups and countries, but also stating what you know from before, that if we are going to reach the target and save life and reduce morbidity, we need to first and foremost prevent, and then the next thing to do is to manage. So what is happening just now? And many of the countries in the European region and globally has been heavily impacted, as you know, by the COVID-19. So it is business as unusual, and it has actually been disclosed that there is a deadly interplay between COVID-19 and NCD, and that has even made the critical juncture more pronounced than we knew from before. I have already spoken to the fact that the first 10 years of the NCD journey, we had a 15% decline of the risk of dying between 30 and 70 years from major NCDs, and that the progress has dwindled. So only 3% additional decline came around the last 10 years. And as we spoke to, an increase even in diabetes, which is of a great concern. And since the outbreak, we have seen that people living with NCD are at the highest risk of being vulnerable and becoming severely ill and die from COVID. And in addition, the disruption of services has been affecting and impacting on the people living with NCD in a very, very big way. So the long-term upsurge in deaths from NCD is likely to be very dramatic. We don't have figures on the exact figures yet, and we need to build back better. So I mentioned the deadly interplay, and these are some figures you can see from Australia. Diabetes and cardiac diseases were the most commonly reported comorbidities of COVID-19 patients admitted to the ICU. And in Italy, we saw that people dying in hospitals, 67% of the people living with hypertension and 31% were people living with type 2 diabetes. We also saw that 30% fewer cardiac emergency reached the facilities in rural India during the COVID pandemic. And in Netherlands, we also saw that the diagnosis of cancer dropped by 25% because of the lockdown. So we did a survey during the early months of May, and this was done because we were really alerted by healthcare workers and also the civil society that this disruption for people with living with NCD was very serious. 163 member states responded to the rapid assessment survey, and they reported that half of the countries had complete or partial disruption to hypertension management, to diabetes, to asthma and palliative care, and also urgent dental care. And cancer treatment in this survey showed a disruption of 42%. And we have a newer one that was published 2 weeks ago showing that the cancer treatment actually was more impacted, up to 55%. And also the services for cardiovascular emergencies. When we looked at the survey, and it's published, and you can see the publication on the left-hand side, we of course saw that the more dramatic the pandemic, as we were moving through the pandemic phases, the more disrupted the services became. We also saw that unavailability and stock out of essential medicines was mentioned as the main reason of disruption in 40% of the low-income countries. We were very interested to know if NCD was part of the national COVID-19 plans, the national response and preparedness plans. And in May, it was mentioned, but when we looked into it, it was really not included in the plan. After May, we had a renewed global response and preparedness plan, also including what we call the Pillar 9, also including the response to diseases. So we expect, and we are trying our ever best now to support countries to, in a much better way, include also non-communicable diseases in the national plans. And this is, of course, extremely important. We have a lot of financial support now for countries to restore and also to build back better. And we have to make sure that these financial resources is also used to build back better on NCD. So this is another picture of the different reasons for disruption. And as you can see that the decrease in inpatient volume was because of cancellation of elective care was the main reason. And to some extent, this is also what we have recommended, but we also know that in these figures it's also a lot of misinformation, disinformation, fear of going to hospitals, and we need to look into this. Together with Rudiger Kretsch, I have been leading a COVID-19 working group on NCD, and Jill Farrington, who is going to speak after me, has been heading the secretariat. And this is a working group that has been working across all the regions of WHO, and the real way to really address what is the gaps, what is the needs from countries, how can WHO best support. And we are looking into many of these issues. And as you can also see, there was also deployment of critical staff to COVID was mentioned as some of the reasons for the close down. Also, of course, a very important reason of the disruption was also the lockdown of the public transportations, insufficiency of staff, closure of outpatient clinics, and as I mentioned before, also stock out and unavailability of essential medicines like insulin. So this is another picture just showing the same analysis also across the income levels. I don't want to get more into it now, but please have a look. It is a lot of very important information when we are now focusing on closing the humanitarian response gap for NCD and also building back better. The good thing was that the survey also gave some very important information for the future. And I think this speaks very well to the core focus on the Almasov work as well, because you can see that digital health and telemedicine, and also the focus on task shifting and triaging is among the most important most important mitigation strategies. So telemedicine is actually one of the mitigation strategies that has been used across the board, across regions, and across income level. We have a task group that is looking into how can we learn what is the innovative work that has coming through. And of course, it is of a big sort of both a little bit of a surprise, but also encouraging to see that many of the recommendations that has been very hard to implement suddenly among 5-6 months has been implemented across almost all the countries of WHO. So in a nutshell, the pandemic has laid bare how the world has failed to meet the healthcare needs of people living with NCD in the majorities of countries. And I have mentioned a couple of these publications during my speech so far, but I would like again to mention that we have very recently a new survey that showed that the most frequently disrupted healthcare services include NCD diagnosis and treatment in 69% of the countries, and also cancer diagnosis and treatments in 55% of the countries. So the deadly interplay has again been documented. We also had a Lancet paper coming out showing that without a much more clear inclusion of NCD into universal health coverage, we will not be able to reach the targets on UHC either. I mentioned the countdown, and I would also mention the last paper, which was a very important paper from the UN Interagency Task Force. It was a policy document bringing all the UN agencies together in the same narrative, and also bringing them together to include NCD into the COVID-19 response plans. So on the basis of all this work, we are also starting to develop the concept of building back better. And I will not go into details, but I think this can also be a basis for collaboration with you in the future. I think one of the things we learned was that we need to bring the people living with NCD to the decision-making table. We need to, of course, continue the work on the best buys and work without any sort of change, or rather a scale up on the prevention of NCD. We need to include NCD into primary healthcare, into UHC, and we have to really strengthen the economy of the countries, and at the same time reduce the health impact of tobacco, unhealthy food, and also alcohol by increasing the fiscal measures. And we need to focus on data, we need to learn, we need to use the information also on the comorbidities to better build scenarios, and also to inform the national pandemic response plans and the way we shape the NCD agenda towards the next high-level meeting in 2025. I would also very quickly mention that, of course, there is a lot of ongoing work in WHO, and we have the great opportunity to work under the umbrella of the UHC partnership, and also together with the GDO on NCD under the European office in Moscow, on really implementing NCD on different platforms. So we are focusing on governance of integration of NCD into primary health care and also to other programmatic areas. We are, of course, looking into how can health financing mechanisms also support NCD, and how can we increase funding for NCD both domestically and internationally. We are looking into medicines and technology, and it was very nice to see that we had private sector also stepping out, giving donations for insulin during COVID, but we need more sustainable provision of also NCD medicines beyond COVID. And we need to work more closely to develop the health workforce and have competency-based framework really adapted to primary health care and to other secondary and tertiary levels. And we need capacity building and we need to focus on the service delivery and be clear on what is essential services for NCD. And I know that you are doing a lot of work that I hope will inform this journey as well. So we have recently added and updated many of the HEARTS packages, and just recently we updated the HEART technical packages on CVD in primary health care and diabetes. And we have also just recently developed new packages for the UHC WHO repository on NCD. And I'm very proud to say that the PEN package, the package of essential NCD interventions for primary health care, was just recently published, and we will launch it more loudly in the coming months, and hopefully this will also be interesting for you to work on and to further develop. So we are improving the access to medicines, as I mentioned, and we are also strengthening the workforce capacity for NCD. And there is a suite of NCD-focused training packages, and some of them are also done together with the GDO in Moscow and other partners, as you can see, with Oxford University. And I think for the next few coming years, we have to step up and really engage all strong academic institutions to support this work, and also focus on the healthcare strengthening for NCD healthcare workers. We have recently published country stories, because we think learning from what is actually happening in countries, and from the European region, you will see Georgia, and I know that Dr. Jill Farrington will go more into what is happening in Euro, and of course I'm extremely proud of the work of the Euro office and of the work we have done together during the recent years. So I will end my presentation, which I hope was useful for you. And again, I'm extremely proud that you invited me to speak to you today. I wish you a lot of luck with the rest of the meeting. And you can see that the Building Back Better agenda is both on Tedros' agenda, on the ADG Dr. Ren's agenda, and of course, we will continue together with you to advocate for this agenda. Thank you very much and have a nice day. Thank you.
Я думаю, нам очень важно всем сознавать, что нынешняя ситуация, как и мы все оказались перед лицом неожиданной, малоизведанной проблемы, сознавать, что работа идет по всему миру. Мы будем надеяться, что она возымеет эффект через некоторое время. И я с удовольствием передаю слово госпоже Джилл Фарингтон, также представляющей Европейское региональное бюро ВОЗ, отдел неинфекционных заболеваний, которая как раз и осветит вопросы, касающиеся борьбы с неинфекционными заболеваниями в Европейском регионе Всемирной организации здравоохранения в условиях пандемии COVID-19. И сразу после выступления Джилл Фарингтон мы подключим нашего американского коллегу, профессора Пола Казали, представителя американской коллегии кардиологов, который глубоко и давно занимается вопросами как раз ценностной медицины. И его доклад будет посвящен возможностям перехода к ценностно-ориентированной модели оказания медицинской помощи в эпоху COVID-19. Спасибо. Джилл Фарингтон, пожалуйста.
Good morning, afternoon and evening, everybody. I'm very pleased to be able to join my dear friends and colleagues at the Almazov National Medical Research Centre. My name is Dжилл Farrington. I'm coordinator non-communicable diseases at the WHO Office for Europe. And I'm also have a joint role working with WHO headquarters and all other offices of WHO around the world on NCDs and COVID. What I would like to do today is to follow on from my colleague, Dr. Bente Mikkelsen. I know that she's already been telling you about non-communicable diseases, the impact of COVID, and of current work that is being carried out in her office. What I'd like to do is also similarly talk about some of the work that we're doing in the European region, some of the challenges we're facing on non-communicable diseases, particularly during the COVID-19 pandemic context, and also look at some of the current work that we're doing, also in collaboration with colleagues from the Almazov. As Dr. Mikkelsen has already shared with you, there are a number of global health goals which we are trying to achieve. There are two in particular that I will be focusing on, two targets which relate to goal number 3 of the Sustainable Development Goals. The first one is around achieving universal health coverage, and that is just reducing financial risks which people face when they're trying to access care, but also to ensure access to healthcare services and medicines for all. I'd like to focus on is the target on non-communicable diseases, which is to reduce by 1/3 the premature mortality from non-communicable diseases. So we're focusing particularly on 4 major diseases: cancer, cardiovascular diseases, chronic respiratory diseases, and diabetes, and particularly trying to reduce deaths between the ages of 30 and 70. I think Dr. Mikkelsen has shared with you that globally, the world is not on track to meet those targets. Within the European region, we do expect to be close to achieving the target for the region as a whole, 53 countries. But different Europes within the one European region. So if we compare the eastern part of our region, the Commonwealth of Independent States countries, with, for example, those at the most western part, the original 15 member states of the European region, we see a very different picture. So if we look at the red line, in both cases, for both sexes, there are reductions. The probability of dying young in the eastern part of the region is around 1 in 4, and twice as high for men, the green line, as for women, the blue line, whereas it's around 1 in 10 in the western part of the region. And these big differences are largely caused by excess cardiovascular mortality amongst men. If we look at some of the risk factors which are leading to those big differences, as you might expect, the high blood pressure, high blood cholesterol, overweight and obesity, looking at alcohol, showing the differences between the east and west of the region, and those differences for a number of these risk factors, particularly alcohol and tobacco, are quite marked between men and women. In the work that we're doing, we're very much trying to implement and scale up implementation of effective and cost-effective interventions, often known as the WHO Best Buys, and other effective interventions. I pick out 2 particular sets which link with clinical care and particularly relevant for the work that we do with the Almazov Center. So cardiovascular disease includes clinical prevention, identifying people at high risk of heart attacks and strokes, acute care of heart attacks and strokes, and also rehabilitation, for example, cardiac rehabilitation, care of acute stroke and rehabilitation in stroke units. And then for diabetes, achieving good glycemic control, diabetic retinopathy screening, and other prevention of complications amongst people with diabetes. Many of these services and interventions have been particularly challenged during the COVID pandemic. I guess in your country as well, in many countries within Europe and worldwide. Dr. Mickelson has already shared the global results of a survey that was carried out by WHO in of this year. We found in the European region, of the 53 countries, 39 countries responded. And of those countries, this is the picture that we could see for the different services relevant to non-communicable diseases. What we were finding were that the services which were most disrupted, that's partly disrupted in green or completely disrupted in blue, were those which were more in the communities. Rehabilitation services were disrupted in around 80% of countries responding. Hypertension, asthma, services in primary healthcare, for example, were disrupted in around 2/3 or just over half of countries. But the services which were more at tertiary care level or acute specialist services for cancer, cardiovascular emergencies were less affected. If we look at what some of the causes were for those disruptions, we also see some differences between the European countries and other countries in the world. So the dark blue here is the global picture, and the light blue is the European picture. We could see that frequently services were being disrupted, maybe intentionally. For example, population screening programs were being closed or paused in order to reduce encounters within facilities and try to adhere to infection prevention and control. We could also see, for example, elective care such as surgery was being cancelled. But we also could see that there were some things which were perhaps unanticipated. So maybe due to lockdown measures across countries, across cities, or also perhaps patient fear of accessing services, there were fewer patients attending outpatient services, for example. And that was a big difference between the European region and other parts of the world. Around nearly 3/4 of countries in Europe reported that. It might also have been that within the European region, there were also mitigation strategies which were possible more easily. So, for example, changing outpatient to carry out online or through digital means, and that might perhaps not have been so easy to do in other parts of the world. In order to support countries to try and keep essential health services running, WHO has issued a number of different guidelines or guidance, technical documents. This is one that I've personally been involved with, which is around maintaining essential health services, operational guidance for the COVID context. And this document is also available in Russian. The document has two parts. The first part goes through, in general, operational strategies, so general things which can be put in place to support any health service that needs to continue. So, for example, improving the way that or changing the way that different services are delivered. I've already given the example of switching outpatient appointments from a face-to-face delivery to an online delivery, for example. Maintaining the availability of essential medicines. So, for example, providing supplies of medicines for people, longer for people at home, or devices for monitoring their own diseases, for example. The second part of the document gives life course and disease considerations. So for all of these different conditions, or stages in life, the relevant services are be the particular modifications that could be used in order to maintain the services in a safe way, again, supporting infection prevention and control. Again, we were involved in developing the section on non-communicable diseases, again, focusing on 4 main diseases around the continuum of care. So very similarly, linking to what I showed you earlier in terms of the essential interventions, and then seeing how these might be delivered within a COVID context. What we also did in the European region was try to share experiences from the field, how different countries were responding to that and coping with the challenges faced with. And these are some of the examples we have, which are available again in Russian. And it's something that we would particularly be interested to follow up with the Almazov on, to see if we can gather some of your experiences and to share them with other countries. Other areas of work and collaboration that we've had with the centre. This is a piece of work on screening that we are doing. So population level screening programs, that's inviting the general population to have health checks or to be screened for different conditions. And what we're finding across Europe is there's almost an epidemic of screening. It's very popular to set up screening programs, but we can see that there is a need to ensure their effectiveness and to make sure that they do not cause more harm than good, and that they are a good use of resources. So we have technical consult with a group of experts and some member states, where we were designing what was needed and choosing the particular topics. And then we had a conference in February this year, which again, a colleague from the Almazov participated in. And we were there, and we presented our short guide on screening programs, how to implement these effectively, and also a policy brief on screening. Again, these are available in Russian and English, French and German. We then have been following up that work with some more specific look at particular screening programs. Again, a colleague from the Centre on a review and synthesis of the evidence on systematic population level screening programs for reducing the burden of cardiovascular disease. And this document will be published by the end of next month, and again will be available in Russian as well as English. We will the impact of screening on reduced morbidity and costs related to the development of cardiovascular disease, looking in particular at screening for risk factors for cardiovascular disease, as well as certain preclinical conditions such as atrial fibrillation, abdominal aortic aneurysm, and so on. And then we're coming to the conclusion that there was no impact of this population level screening on lowering cardiovascular morbidity and mortality in the general population, and that for some other conditions the evidence was uncertain. Another area of screening that we've been looking at in more detail is diabetic retinopathy screening, and we've been developing a short guide on that, which again will be available next month. We've been following on the left, applying the WHO's Wilson and Younger criteria to diabetic eye screening, and we have been applying a sort of systematic pathway approach. So for example, if through dispensarization or other means, people with diabetes are identified and then have dispensary follow-up, are invited to have their eyes checked, perhaps by an ophthalmologist annually, then to ensure that their eyes are checked in a standardized quality way, that those who are found to have positive screening result, that they have retinopathy that reaches a particular threshold for being sight threatening, that they are followed up in a particular way, they are diagnosed, receive treatment, and that the outcomes are reported. So to follow that kind of classic systematic approach to screening applied to diabetic retinopathy. And again, this is an area for which we are developing a Russian case study to link with this. Thirdly, in this set of documents, we are looking at how do we improve the quality of care. Again, a colleague from Almazov was with us in Moldova, in the Republic of Moldova, where we were applying a feasibility study for implementing the essential NCD interventions I showed earlier at primary healthcare level. So identifying people at high risk of heart attacks, of strokes, and treating and following up people with hypertension, diabetes, and other cardiovascular risk factors setting. And this example that I show you was from Moldova, but we also had done similar feasibility projects in Tajikistan, in Turkey, in Ukraine, and some other countries. And for those, we were using a set of indicators that we were using to assess the quality of through medical records, and then to give feedback at regular intervals to clinicians on their performance in managing these conditions, and then to use again for evaluation. So this CVD assess implementation list indicators again will be published, I think, next week, and again is available in Russian and in English, and suitable for using in low and middle income and high income settings. We've also been working on acute care and rehabilitation of heart attacks and strokes, and I've shared this information on previous presentations that I have done with colleagues from the Almazov. This is a long-standing piece of work in Kyrgyzstan, again with the support of your centre. What we are doing following this is we're also creating an audit checklist based on international indicators, which it was feasible to use in settings such as in Central Asia. And we will be publishing that material as we did for the primary healthcare tools and the training that goes with that. And then finally, some work that we've done during the COVID pandemic is in May and June, we set up a series of webinars on, again, maintaining services for different conditions during the COVID-19 pandemic, and we were very pleased to be able to share experience from the Almazov Center on how they had managed to deliver quality services for patients with acute coronary syndrome. And that webinar was joined by over 100 different institutions from across Tajikistan, Uzbekistan, and Kyrgyzstan, and was very well received. And again, as I said, we would like to follow this up with further webinars and further case studies and examples in supportive countries. So I hope that's given you a good overview of some of the areas of work that we are doing at the moment, and we look forward to continue the work and collaboration that we're doing with the Almazov Center, and thank you very much for your attention.
Thank you, Professor Schlachto and the Russian Society of Cardiology for the invitation to participate in this forum and scientific session. And congratulations. I want to congratulate the Almazov National Medical Research Center on its 40th anniversary. I hope we have the opportunity to celebrate this important milestone together in person with all of you next year. So my talk today is on moving to value-based care in the era of COVID-19. So first, I thought we should talk a little bit about what is value-based care. So value generally is defined as health outcomes achieved per dollar spent. And this was a definition that was suggested by Michael Porter at the Harvard Business School and has been widely accepted. Value-based healthcare, a definition from the New England Journal of Medicine, rewards clinicians and hospitals for helping patients improve their health, reduce the effects and incidence of chronic disease, and live healthier lives. And I think these two definitions are important to level set the discussion around value-based care. But most importantly is value, and the definition of value, it depends on your perspective. So for patients, value might be ease of access to care or the affordability of care. From a clinician's point of view, it's often viewed as high quality care. For those paying for the care, they often equate value with cost or low price. And for employers, when they look for value, they often equate this with price for quality. So in the United States, why are we talking about value-based care? Well, in the United States, you can see the national health expenditures for healthcare have dramatically increased over the years and is expected to cost approximately 20% of our gross domestic output and approximately 5.5 trillion within the next few years. And in the United States, when we look at this growth in healthcare program cost, we realize as that increases, the ability to spend money on everything else decreases. And of course, this is becoming a bigger challenge as the population continues to age. But this is not a problem that's limited to the United States. If you look at the projected healthcare spending around the world, you can see that estimates for cost for 2022, which are in red compared to 2017, really are increasing everywhere. And globally, you can see the large increase in healthcare spending, and then by areas of the world, again, consistently, we are projecting to see large increases in healthcare spending. In cardiology particularly, and this relates to the United States, but I think this is around the world as well. For the US, cardiology accounts for 20% of all of the healthcare spending in the system. And for the elderly population, which is the Medicare population, cardiology accounts for 30%. And I think these numbers are consistent worldwide, where cardiology and a need for cardiology care and the demand for cardiology care continues to increase significantly worldwide. So how do we approach, from a health policy perspective, on lowering spending, seeing that the costs continue to rise exponentially? Well, one of the ways is to reduce prices. The challenge with this is that as you reduce prices, this may limit access to care for patients. And most importantly, simply reducing prices does not directly improve quality. Another approach is to change payment and coverage to support better care. And this is where value-based care payment models come into play, with the approach being to improve patient experience and outcomes while lowering spending. And to do this, align incentives of the patient, the physicians, and those paying for the care. So as an example, in the United States, there have been several studies that have looked at where the money is being spent. And you can see here, if you just look at the areas where there are failure of care delivery, failure of care coordination, or overtreatment or low value care, you can see that that's over 35% of the total spend. So even putting aside that in the United States, we have administrative complexity and we have issues with pricing, and those may not be relevant around the world, but care delivery issues, care coordination issues, I think those are global challenges and opportunities for reducing costs. And this slide is really just to remind us that it's really a small percentage of patients who account for a large amount of the cost. So this again is for our elderly population in the United States. You can see that the top 1% of beneficiaries account for 16% of all costs. And if you look at that top 10% of costs of patients, you can see that's over 50% of the cost. And again, I think this is similar around the world, where the complex patients are the ones where that drive the cost and where there's opportunity to improve value. So how do we better coordinate care? How do we manage these patients better, improve value for the system? In the United States, and I think in my discussions with others around the world, these challenges are similar around fragmentation of care. So if we can improve the collaboration and coordination of care between primary care and specialty care, if we can improve the collaboration and coordination of care between inpatient and outpatient care, and then around home health and what we call post-acute care for those patients coming out of the hospital. In the United States, this is a very fragmented system. And in other countries where there may be less fragmentation, there's still, from a clinical point of view, opportunities to improve that care coordination. And often that's due to lack of communication or appropriate follow-up or medication management issues or diagnostic errors. So clearly opportunities to improve value, meaning improving quality, lowering costs, if we address some of these clinical challenges on fragmentation of care. And when we think of how payment models work within these care models, here's some examples. So fee-for-service, where physicians, other clinicians are paid for their service in a unit value. This maybe works in something such as treatment of a urinary tract infection. However, for more complex care, so for condition-based, such as multiple sclerosis, or bundled payments for something like a knee replacement, or for a PCI, or for a bypass surgery, the idea and value is to create centers of excellence and sort of focus factories where expertise is concentrated that allows improved quality, lower costs, and ultimately a improvement in value-based outcomes. And then finally, there's population-based global payments, and there's clearly interest in moving to total cost of care. An example here being total cost for frail elderly patients, and this is really focused on team-based care across settings. So when we talk about bundled or episode payment, again in the United States, we have several initiatives. The ones in cardiology are in bold on this slide. So there are inpatient episodes. Some of them are clinical, such as acute myocardial infarction or congestive heart failure or cardiac arrhythmia. Others are more procedurally related, such as PCI and bypass surgery. But you can see that we also have quite a few in orthopedics and musculoskeletal, as well as GI. And the way these are structured is they're 90-day episodes in which the physicians and hospitals working together are responsible for the total cost of care with risk-adjusted target pricing. So this is a very different approach than the standard fee-for-service that's currently in place. The other model that has really grown in the United States is accountable care organizations. And accountable care organizations are defined as groups of doctors, hospitals, and other healthcare providers who come together to give coordinated, high-quality care to their patients. And so you can see here that the number of ACOs has grown significantly over the past 5 years. And in these organizations, total cost of care is accepted by the organization, and a certain population of patients is then managed by the ACO. And again, this is not unique to the United States. If you look in this study, looking at a survey of several countries around the world on the international move to value, you can see with fee-for-service on the left, and then evolving fee-for-service, where it's fee-for-service with quality measure outcomes, and then ultimately to capitation. You can see that there are more and more countries who are experimenting with these value-based payment models. And here are some examples. So in England, the NHS has a series of new care models, which they've tied to payment. One here example is the integrated primary and acute care system. In Canada, the Canadian Foundation for Healthcare Improvement is identifying opportunities for improving the care model and then connecting that to a value payment model. And then finally, another example is in Brazil, where there is pilots and interest in moving towards value-based healthcare throughout Latin America. So how does this relate to COVID-19? So COVID-19 has had an unprecedented impact on the US healthcare system. Utilization during the surge of COVID-19 in the US, healthcare utilization declined rapidly. Initially, both in the outpatient and inpatient, up to 60%. And although much of that care has rebounded, still not returned to normal activity. And with that, there's been steep financial costs to the hospitals, to physicians, and to the health systems, with estimated losses of over $300 billion in 2020. And physician practices in particular have seen even larger losses. In terms of a workforce impact, the healthcare sector has lost over 1.4 million jobs back in the initial surge in April and has not achieved full recovery. And this has all required significant federal financial assistance of over $200 billion in direct payments to hospitals, physicians, and health systems. And we're still in the midst of the pandemic. As we are all aware around the world, and this is in the United States, we're continuing to see a large number of new cases per day. And where I am in New York City, where we had the surge early back in March and April, you can see that we're starting to see an uptick of cases here in October. And in New York City, we also see that COVID cases affect Black Americans and Hispanics to a significantly larger degree than others. And if we look at COVID cases by poverty level, again, those with high, very high poverty levels, the number of cases is significantly higher. So in fact, COVID-19 has highlighted the inequities to access to care and health outcomes. And around the United States, we see that Hispanic and Black Americans account for a disproportionate share of COVID-19 cases, hospitalizations, and deaths. and that the racial and ethnic disparities have really been identified universally throughout the United States. But this is an issue, although highlighted by COVID-19, has been an issue in the United States even before. So this slide shows expected age of death, so survival starting at the age of 40 years old, based on your household income, and again, separated by men and women. So you can see that income-related health disparities are large. And this again highlights that when we think about value-based care, we have to think about the social determinants of health, because in fact, healthcare represents a relatively small percentage in terms of the determinants of health and contribution to premature death. And in fact, behavioral patterns and genetic predispositions, as well as social circumstances, account for the much larger impact on one's health. And you can see that in the right, where you can see behavioral causes of deaths, where obesity and inactivity and smoking are much significant contributors to death. So how has value-based care been enabled within the COVID response? We have seen in the United States a focus on new care models in responding to COVID in order for practices to be able to adapt. And they've done this by, for example, being sure that they have sufficient PPE across practices. They've developed robust data infrastructures for managing populations of patients. And so in COVID, it was important to track their patients, looking at utilization, looking at geographic variation, and having predictive analytics for care support. And this was all built up relatively quickly in response to COVID-19. And these are tools that are helpful in any value-based care model. The move to telehealth, again, that's not just in the United States. We see that globally, that has accelerated quickly, and the ability to use remote monitoring tools. And this, of course, is all enhanced by building team-based care. And ultimately, these are all helping to address the COVID-related health disparities. So when we think about new care models for COVID-19 and beyond, again, these are based in primary care teams with enhanced capabilities, particularly the development of virtual care, and applying increased data support in order to manage populations of patients. And these models have also integrated behavioral health service, as we know that this has had a significant impact on overall patient health. Remote patient monitoring by enhancing home and virtual care models has been implemented widely. So in cardiology, for instance, we have a robust model for managing heart failure patients in the home using a remote monitoring technology. And by virtue of using this remote patient monitoring, allow patients to stay home so they do not end up coming to the emergency room. We've reduced the need for them to be admitted to the hospital. And of course, there are many other examples, including end-stage renal disease, for management of oncology patients and just complex patients in general. And of course, as I mentioned, these new care models need to address social isolation, mental health, and then hunger. So providing food resources for patients, particularly during COVID when there's tremendous social isolation. And as I mentioned previously, ensuring that the social determinants of health are addressed. So with that, we see greater investments in value-based models to develop or enhance the capabilities for establishing telehealth, remote monitoring, and of course, improving the patient engagement around these virtual platforms. Also, as part of this, training a workforce to support care coordination, as I highlighted earlier, fragmentation of care is a significant issue leading to higher costs and lower quality. And so having a team-based care and trained workforce to support that care coordination is critical. And as I mentioned, addressing the social needs. And in order to do this, robust data systems are needed for population health management so that these high-risk individuals, who tend to be those that are high cost, can be identified and managed through these care coordination support. And then building this capacity for home and community-based delivery, not just of primary care, but cardiovascular care, as well as mental health services and other specialized care needs. So what we're seeing as value-based payment meets the COVID-19 response, we've clearly seen the challenges in our current fee-for-service system. Not only the fragmentation with little coordination that's inherent in fee-for-service payment models, but fee-for-service models tend to be reactive, as we see with the surge in COVID cases. And of course, from a financial point of view, the revenue decreases, which led to physician practice closure, staff furloughs, and an inability to really meet some of the needs of the patients and the practices. So as we think about moving away from fee-for-service, moving towards fee-for-service with shared savings. And this is a way to start thinking about how we might manage costs better and improve outcomes. But ultimately, moving towards prospective payments and ultimately to these bundled payment episodes, which in cardiology can be procedural bundles or episodes or clinical bundles such as acute MI, and capitated payment, so that for a population of patients that are appropriately risk adjusted, identifying the appropriate payment for managing those patients over a set period of time. So where do we see the future direction in value-based medicine? Aligning payment more closely with episode of care models that lead to better outcomes and lower spending. Deploying evidence-based care pathways across the care continuum. And this is where the collaboration between the American College of Cardiology and the Russian Society of Cardiology to help, and other societies as well, to help build and collaborate on these care models that can be deployed across the care continuum. And engaging specialists, as I said, in creating the pathways and specialty societies. And the result will be reduced unwarranted clinical variation and low-value interventions. Also, key to moving to these episode of care models and value-based medicine is having more efficient team-based models and providing care in the lowest cost care setting possible. And of course, cardiovascular specialists need to be part of the multidisciplinary team, and enhancing care coordination and continuity of care is critical to this. And as part of it, always thinking about the social determinants of health. And finally, incorporating shared decision-making, being sure the patients are at the center of the care and are part of the decision-making process, and that we incorporate patient-reported outcomes into any of our quality measures. And then finally, as we think about value-based medicine, improving prevention and management of cardiovascular disease. So in closing, I just want to summarize using the alternative payment model framework from the American College of Cardiology. What we've created as we think about moving to value-based care is that there are 4 areas where organizations and physician practices need to be sure that they have built the infrastructure in order to move to new payment models. One is around organizational readiness. And this is important to identify external partnerships. Is the workforce in place that will allow the move to different payment models? Reporting and analytics. I mentioned a few times in this talk the importance of data, information infrastructure, data analytics, and ability to report. And this is critical for physicians as they understand the patient population in which they're being responsible to manage, and understanding the care that they have received for these patients, and where there's opportunity to reduce costs and improve quality. Financial risks. Many of these models in which you're moving from fee-for-service to either a bundled or episode of care or to full capitation, there is an entity that's taking risk. And so having an understanding of the ability to take risk as an organization is critical. And then the last piece, which I think is most important, is the clinical practice transformation. And I touched on this throughout the talk. So being able to have an infrastructure to support care coordination, to support improving quality performance measures, to engage patients, to provide access to care, improving access to care, and understanding the patients that are being cared for by the providers collectively as physicians, hospitals, and health systems. So I will close by saying again that we see a rapid rise in the cost of care across the world. Some of that is being driven by an aging population and the complexity of care that is needed to be provided to patients. And so we see opportunity to manage those patients better through improved care models, and with that, improvements and changes in value-based payment. So I look forward to further conversations and collaborations with the Russian Society of Cardiology and others as we collectively look for the best way forward to improve value-based care for our cardiovascular patients. Thank you.